I think we should get started, if everybody agrees. Looks like no, Ajay is not supposed to be here, so I think we have everybody here. Vice, I feel sorry you're all by yourself. Maybe come a little closer.
Come a little closer.
Come a little closer. So good afternoon, everybody. I'm Azeem Latib from New York. I'll be moderating this session. Unfortunately, Dr. Leon sends his apologies. He can't make it for the session. But you do have an amazing panel that's going to help us really talk through the role of Sirolimus Coated Balloons in the U.S. market and how it's going to, transform coronary interventions. So joining me, I have Prathap Kumar, Vice, Marco, and Bernardo. And we're going to try and give you really an overview of the Magic Touch Sirolimus Coated Balloon program, give you a little bit of the background of how this device works, show you some of the clinical data that's out there, talk about how this is going to impact us here in the U.S. I think we are living in a very exciting time in the U.S. because finally we will have drug-coated balloons available for our patients. And then we'll take you through some complex cases where some of our panel will share some of their experience with Sirolimus drug-coated balloons. So we're going to get started, and Bernardo, you're going to start us off talking about the global clinical experience with Magic Touch.
Right, thank you, Azeem.
I'll just say before Bernardo starts, we have microphones. There's also an app if you want to use the app, but please ask questions.
So yeah, I will go through these big, actually not 3 but 4 clinical trials that have been published or are ongoing on this novel technology that we have, and that was the first one which came into the market for DCB after paclitaxel. So we have a number of paclitaxel. Now we have 3 Sirolimus Coated Balloons in Europe, but as Azeem said, in the US, we only have 1 paclitaxel with other devices that are approaching. So the clinical program of this device started with the simple lesions, small studies with angiographic follow-up, and then went through a more complex lesion and patient setting. And as I said, I will start today with a presentation of EASTBOURNE. EASTBOURNE is a real-world, all-comer prospective registry, including European and Asiatic patients. We had an independent CC. This is not a sponsorized trial. It's an investigator-driven trial by Fondazione RIC, and the primary endpoint is TLR at 1 year follow-up. This is the performance of the centers that enroll patients at EASTBOURNE, and in the end we were able to enroll 2,123 patients with 2,440 lesions treated, all of them with this Sirolimus Coated Balloon. This is a quite busy table showing the characteristics of the patient population. You can see that, it's a quite real-world population with a lot of diabetic patients, a lot of multi-vessel disease, many patients had a prior MI, some of them had CABG, real-world patients that we treat with a drug-coated balloon, at least in Europe and in Asia, with substantially 2 indications, which are ISR and de novo. De novo in this case, in a vast majority of the cases, were small vessels. Okay, so below 275, if we accept this cutoff. So the primary endpoint, which has been published last year of this prospective registry, TLR was 5.9% in the overall population, MI 2.4, death in 2.5% at 1 year. And if we split the indication for using DCB in this study, you can see here that TLR in de novo is very low, 2%. It's higher, it's 10.5% in the ISR group, like we have seen for other paclitaxel coated balloon at 1 year. The rate of TLR is very similar and accounting between 8 and 12%. We also have the 2-year follow-up, which we published recently of this registry, and the 2-year follow-up is showing, sorry for this, the quality of the slide is not that good during the transition, is showing, from the Kaplan-Meier, it's easier to see that the late catch-up between year 1 and year 2 is pretty low, mostly in the de novo setting, but also in the ISR. So the plus events that we have recorded, and as I was mentioning before, all of the events are CEC assessed, were quite low between year 1 and year 2. So this is quite reassuring for the quiescence of the lesion that we obtain with this device. Then there is, we published quite a lot in terms of sub-analysis from this study because we got a lot of information. This is one of these sub-analyses showing that not only after paclitaxel, but also after sirolimus coated balloon, if you have a dissection, if it's not flow limiting, if it's type A or B, you can leave it safely. Here we have the 12-month follow-up showing that in the dissection cohort, the outcome is similar to the non-dissection cohort, maybe also a little bit better. For paclitaxel, we have seen that the more you dissect, the better it is for the drug to penetrate into the vessel wall. The other big question that we have is how is the performance of DCB in large vessel? So we don't have so far strong data. We only have this sub-analysis of EASTBOURNE in 810 patients, 181 in de novo, the rest in ISR, which is showing how the clinical performance of this device is still good with a good safety and a good performance also in larger vessels. And then we have Transform 1. In Transform 1, this is a sponsored study by Concept Medical. In Transform 1, the idea was to test this Limus-based DCB to a paclitaxel-based DCB in de novo small vessel setting. This is a small mechanistic study which was expecting for the primary endpoint of a net lumen gain at 6 months, the non-inferiority. But unfortunately, non-inferiority was not met by Magic Touch as compared to this paclitaxel-coated balloon because of the non-inferiority margin, but the performance of this device angiographically was not the one that we expected in this setting, lesion setting of patients. We tried to dig a little bit more into the reasons why it didn't work, and what we understood and what we saw can be explained in this slide. So this is just two-center analysis of a small mechanistic study, so just some very superficial information we can get from this. But what we can see is center 1 and center 2, you can see on the left. Magic Touch, you can see that the performance of the device is very different. 0.28 late lumen loss, 0.10. On the right, the same two centers. Paclitaxel, negative late lumen loss, minus 0.11, and in the other center is worse than Magic Touch. So there is a very high variance of the performance of these two devices. And going into analyzing the lesion settings, in the center where paclitaxel was much better than sirolimus, the lesion setting was more complex, much more complex. In the other center where there was a slight better performance for sirolimus, the lesion setting was much easier. So this is another important information on the importance of adequately preparing the lesion before DCB use. So now we jump from this information into PICCOLETO VI because we know that angiographically paclitaxel will win, always, versus sirolimus. But what about the physiology? So PICCOLETO VI is another independent investigator-driven study with a core lab. What it's important to underline about this study is that we designed the protocol in order to assess the physiological performance of several types of paclitaxel and sirolimus coated balloon. We're going to present this data later at TCT. The primary endpoint here is different. It's not angiographic late lumen loss, net lumen gain, whatever, but it's late functional loss during angiographic follow-up. So we collected 300 patients, all of them consecutive, all of them with angiographic follow-up in de novo small vessels. And we analyzed all of them. So this is the calculation of the population. I will go a little bit fast on that. What we can observe from the first results is that lesion length is long, much longer than Transform 1, Bello, PICCOLETO 2, the other small vessel disease studies, 23 instead of 11, 12. So this is the first information that we have. The second information is that, not unexpectedly, paclitaxel won as compared to sirolimus for the QCA data in terms of late lumen loss. Also in terms of lumen gain, we have this lumen gain with sirolimus, but we have more with paclitaxel. This is only a confirmation of what we already saw from other studies. We have it in 60% of paclitaxel and 40% of sirolimus cases. And then we go to the primary endpoint of the study. We had a μFR, which is a angiographic-derived physiological assessment, as I said, performed by a core lab, 0.87, in a paclitaxel-coated balloon, 0.85, and a primary endpoint of late functional loss, not significantly different, with a trend towards improvement, but again, not significantly different in the paclitaxel arm. And the other important information that we got from this study is that we also now have a cutoff for final μFR, FFR physiological assessment for DCB. We have it for DES. For DES, it's 0.92, 91 according to the study. So if you finish with a lower FFR, you have more events. Okay, for DCB, at least from this study, we found we lowered this cutoff at 0.86. And this is a comparison between all of the devices that you can see here. On the left, paclitaxel, on the right, sirolimus. There is no difference in terms of physiological performance between all of these devices. And then we jump into the last study, which is an ongoing trial. It's a Transform 2. It's a randomized clinical trial. Primary endpoint is TLF at 1 year. So we have a clinical endpoint, and now we compare Magic Touch to jump too fast, to the Science. We will follow up patients up to 5 years, and we are including patients with up to 3.5 millimeters on lesion length. Enrollment is ongoing. These are the countries and the centers that are participating. We have reached 1,200 patients out of the 1,800 patients that we have planned. So my final comment is that the need for an adequately powered RCT on large vessels with sirolimus coated balloon is eagerly awaited and needed so far, because we have some conflicting data from paclitaxel with a REC cage-free 1 trial. We want to see if sirolimus is able to maintain a good performance in these lesion settings. Thank you for your attention.
Great, thank you so much, Bernardo. I think we have a few minutes for questions. So before I pass it on to Marco, because I can tell he has a question for you, maybe just for the audience, you mentioned on your last slide, REC cage-free. Do you want to just maybe not everybody knows this study. It was presented at ESC. Just maybe briefly a 30-second overview of what the study is and the limitations.
Yeah, this is a very important study presented at the ESC a few months ago and published in The Lancet. You can see publication in The Lancet. It's a randomized clinical trial of a paclitaxel-coated balloon, the swine DCB, compared to stent, latest generation drug-eluting stent in an all-comer population with any vessel size. So the primary endpoint of non-inferiority was not met at 1 year in terms of clinical performance by this paclitaxel-coated balloon because there was an improvement in the DES. Then they went through an analysis according to the vessel size, which will be presented during TCT by Patrick Serraius later, which is showing how in the small vessel disease setting below 3.0, there is no significant difference between the two devices, where in the largest setting, there are very few events in the DES and more in the DCB group.
Yeah. I guess the one big concern for many of us who see the data is, again, it highlights for me the fact that we all have to remember that, and I'll say this again in my talk too, not all DCBs are created equally. There's no class effect. And when it comes to this balloon, there's very little preclinical or angiographic data that's been published on this balloon. So we don't really know how effective it is, right?
That's right, yeah.
Marco?
Bernardo, thank you. I was asking you whether you could a bit elaborate on this magic FFR number 0.86. Where does it come from? Because that's an important information. So please expand on it and let me digest it.
Yeah, this is an important information that derived by a single retrospective study, okay? So it's not a randomized clinical trial. So one of the questions is, how should we leave the lesion after angioplasty, after DCB? So far we have angiographic information. We say less than 30% percent diameter stenosis, no flow limiting dissection. We wanted to push it a little bit more, so we don't have a wire here, FFR wire. So this is a post-hoc analysis by a core lab with the FFR. So we just collected the events with a 1-year follow-up, and we saw that the cutoff limit was, well, we did 2 analyses. One is dividing in 3 groups, like we did for Colette did for the DES, according to the 3 different measurements of FFR. Colette did it more than 92, from 92 to 80-something, 87, and below 87. We decided to just give a cutoff, and we individuated that with a 0.87.
Bernardo, I have a doubt. You told the dissection, if you have significant dissection, they do better than a no dissection. That is, can you explain?
We have learned this clearly by some Japanese studies, but also from European studies with pancreatitis.
This
The
is
more you
basically
dissect,
by
better
the,
it is, but the dissection cannot be a flow-limiting dissection, otherwise you will have an acute.
it's actually image-guided study?
Yeah,
Or?
that's an OCT study by Yamamoto. It's a very nice, well-performed study.
Right, so maybe we'll move on. We'll have more
I
time.
would like to present, I'm honored to present Azeem Latib, which will present us the current landscape of DCB trial with Magic Touch in the US.
So I think it's a really exciting time in the United States. I remember when I moved here just over 5 years ago, thinking that the device, what I missed from living in Italy, besides the food, the wine, the countryside, the people, I could go on forever, was I missed having a drug-coated balloon in my practice. And the fact that now Bernardo has moved from Italy to the US, you know that problem no longer exists, right? Because he wouldn't move unless there were drug-coated balloons. So congratulations in becoming a US physician and coming to join us. But it's an exciting time because now we have lots of drug-coated balloons. And you're going to help us get these approved. So let's take a little step back and talk about the current landscape and maybe some of the challenges and opportunities for drug-coated balloons. These are my conflicts of interest. So do we need DCBs? I think, when we look, everybody, I have a lot of people who say to me, I get a great result with stents. Stents are fantastic. I get in, I put my stent in, I can go home. I'm not worried about dissections. I don't have to think about residual stenosis. DCBs are more work. But I think all of us know that once we put in a stent, it's not like that's over for that vessel and that lesion, that we continue to see an increase, a slow increase of events from that stent. And years ago, we all hoped that bioreabsorbable scaffolds were going to be this future, was going to allow us to flatten the curve. So have this flat curve long term where events would not continue to accrue. Unfortunately, they had their own limitations, but it did highlight for a lot of us that we needed to do a better job to have better long-term outcomes. So we needed to image better, we needed to predilate better. But also it started highlighting for many of us that if you could leave a vessel uncaged, you could allow positive remodeling, you could allow normal vasomotion, and this potentially would be better for our patients long-term. And I think DCB is now filling that gap where we once thought there was an issue. Honestly, we can't see patients like this anymore. We shouldn't be doing this anymore to arteries. I cringe when I see someone putting in a 48 millimeter stent in my practice and in my group, unless it's in an RCA CTO, then I go, well, it's a conduit, you need to stent all of it. But when I see a long stent going into the LAD, I cringe. And I really do hope that full metal jackets will be something of the past, that those patients can be treated either adequately with surgical revascularization or that using something like a drug-coated balloon will allow us to limit the amount of stents. But certainly, I no longer want to see this in my patients, and I'm very critical of my own team when I see a full metal jacket. Bernardo hinted on this because he's done a clinical study in just about every indication of DCB, except I don't think you've done erectile dysfunction yet. Maybe you can put in your... But there's lots of indications. The most common, obviously, is ISR. and small vessels. But there's, as you saw, there's data for long lesions and looking at how can we tackle long lesions, bifurcation, CTOs. There's also patient-related factors in studies. Can we shorten DAPT in high bleeding risk patients? Could you go to single antiplatelet therapy even in some patients? But one of the things we have learned from drug-coated balloons that this is just a balloon. There's nothing special about it. This just delivers drug. And I think that's why also many of us went away from calling it a drug-eluting balloon to a drug-coated balloon. It's just coated with drug. There's really nothing special about these balloons. I'm sorry to the companies. There's a lot of special research that goes in, but the balloons don't do anything special to the artery except delivering drug. And so we've come to learn that lesion preparation and prepping the lesion well, assessing that result, is extremely important for outcomes for DCB and much more important for outcomes for DCB compared to a drug-eluting stent. Now, there's lots of data, as you know, on restenosis. There's more and more data, including a number of meta-analyses also for de novo disease, and showing that in small vessel you have as good outcomes, maybe even better outcomes long-term as far as small vessels. I was surprised when someone was asking me about this the other day. We published this paper in 2013 with my previous team in Milano, where already then we were trying to figure out, could we stop doing full metal jackets? Could we combine a drug-coated balloon with a drug-eluting stent to stop these patients from getting all these stents? And certainly in that study we were effective. We were able to, using a drug-coated balloon, decrease stent length by 50 to 60%, with actually a positive effect on TLR rates. And now it's great to see 10 years later, we're actually studying that in clinical studies and randomized clinical studies, and hopefully between Bernardo and Marco, we'll have some clinical data. But when you look at small vessels, you've heard about some of the clinical data. Really, the clinical data is really good. It's really good for small vessels, but the challenge has always been that the number of patients treated in many of the studies has been very small, other than Basket Small 2, which was a very large clinical study and with a clinical endpoint. But you see very similar outcomes in green for DCBs, even sometimes better, compared to a drug-eluting stent in small vessels. So when we think of a drug-coating balloon strategy, what are some of the advantages we like to think of? I think it may simplify the procedure. Some don't. Some go, oh, banging a stent in. I love this word also. You're going to have to learn all the American jargon. There's a great American jargon. Bang a stent in. I'm just going to bang a stent in. I hate that terminology, by the way, because we shouldn't just be banging stents in. We should be doing imaging, we should prep lesions, and then we should implant stents properly in the right place. But people often get concerned that if they start doing drug-coated balloons in de novo disease, it's going to make the procedure longer. They're going to have to use their brains a little bit more. I honestly think it can sometimes simplify a procedure. I think sometimes of, when I'm dealing with a bifurcation and I see a distal right and I see this mismatch in diameter and I spend how am I going to stent this? I'm going to have to pot and do this and do that. Whereas actually maybe I could just use a drug-coated balloon and go from the crux into one of my side branches. I think it will give us shorter DAPT or single antiplatelet therapy. It definitely allows for positive remodeling, and certainly, as Bernardo says, the data for paclitaxel is a little bit stronger, but everything we do comes at a price. So there's nothing for free, and maybe the price for positive remodeling is actually vessel toxicity, and maybe that's why we positive remodel, because we're damaging the vessel wall, and that's why it gets bigger. Are we going to cause aneurysms long-term in some of these patients? Maybe. But we do limit the number of stent layers long-term. Some of the cons is, to all the younger people out there who were never in the era before stents, you're going to have to learn how to do plain old balloon angioplasty, and you're going to have to learn how to do it properly. Because to get good results in de novo disease, you have to learn how to do proper POBA, like our mentors did in the days before stents were available. You need to learn how to evaluate and leave dissections sometimes. And sometimes it may be less appealing, but we certainly need to build evidence. So I'm just going to very quickly go through this. I think there's certain advantages of why we developed stents to deal with acute recoil and acute occlusion. DES did deal with a lot of the restenosis issues we had. We hoped that BVS would give us some long-term outcomes, but instead we found out that thrombosis was a real issue when these devices dismantled. And hopefully DCBs will address a lot of those issues. We still may not address the issue of acute recoil and acute occlusion, but I think it will address the issue of thrombosis. I'm just going to move a little forward. So DCBs are many and they're different. They ease no class effect. These are all the DCBs that are available around the world. Some of them in small writing at the bottom are no longer available, but as you can see, they're many. But you have to dig, the devil's always in the details. You have to dig through those details. You have to know how the drug was put in, what drug it is, was it in a crystalline form or not, and what type of excipient was used to attach that drug to the balloon. That all becomes really important. And if you don't look into that, you unfortunately will think they're all similar. They're not similar. And I'll keep highlighting that. So the ones we're going to have available, which I'll briefly highlight here in the United States, is Solution, Magic Touch, Prevail, and Agent. Agent's already approved for ISR, but the other three are all in clinical studies. And hopefully, we will see a higher usage in North America than we have in the past. So let's start with Agent. That's approved. As you know, paclitaxel, coated balloon. We had the Agent IDE trial, which really showed positive outcomes compared to a normal balloon, to POBA, as far as reducing target lesion failure and TLR. So that's available. Solution is another Sirolimus Coated Balloon. That's in clinical studies right now in the United States. They have two studies. They have an ISR IDE study, randomized similar to Agent, balloon versus standard of care. And they also have a de novo small vessel IDE with 910 patients who are going to be randomized to Solution versus a drug-eluting stent. And then Medtronic also has the Prevail balloon that will be in clinical study. This is also a paclitaxel balloon with urea as the excipient. They have one study that in the same study has an ISR cohort that's randomized against Agent, so Prevail against Agent, and they have a single arm cohort for small vessel with 2 to 2.75 millimeter diameter vessels. And then for Magic Touch, who is the Concept Medical is the sponsor of this session, they have, as you know, it's sirolimus phospholipids. I'm just going to very quickly go back just to tell you, we've started the ISR study, which is actively enrolling. It's 2-to-1 randomization against POBA. And we soon will start the small vessel study, which is global, will include US as well as European sites, and also 2-to-1 randomization against the drug-eluting stents. So just to conclude, I think DCBs are effective, both in small vessels and ISR, but they require good lesion preparation. We now have our first drug-coated balloon approved in the United States, and I think we'll see within the next 3 to 4 years many more, at least 3 more, potentially more. But once again, I think part of what we want to highlight in this session is it's great to have this technology, but it also comes with a learning curve, and how you use it is just as important to the outcomes you'll see in the future. Thank you so much.
Thank you, Azeem. So if there are questions, in the meantime, while you're thinking about questions, I have a question for you. So I've seen that in one of these trials that you have presented, there is a registry, a prospective registry comparing to DES data. So now the FDA is accepting this type of studies for obtaining the FDA mark?
No, you're very astute, by the way. I was hoping you were going to miss that. So let me just say, in the Prevail study, they have in one study a randomized arm for ISR against Agent, which I think is probably going to be the way other devices will have to get approved if you want to get ISR, because as Agent becomes more, not readily available, but also reimbursed, I'm not sure, they're also Europeans in this audience. I don't know if you know that in the United States, we pay for an Agent drug-coated balloon, was it $4,500?
$6,000.
Sorry, $6,000, then comes down to maybe just over $5,000 or something. But the balloon costs $6,000. I mean, that is just nuts. That's like more than the whole procedure gets reimbursed, basically. So if you do a procedure in the United States where you use one drug-coated balloon, an Agent balloon, and you don't put a stent in, you actually lose money to the hospital for the whole procedure. You're done. Right, you're done. So it's challenging, but hopefully we'll get reimbursement. There are going to be pass-through payments coming that will make it easier. So what Medtronic did, because they're thinking these payments will be available, they're going to do randomized 1-to-1 against Agent for ISR. To get a de novo indication, you have to randomize against stents, okay? But Medtronic has a lot of data on stents and small stents, because remember, they did do Onyx small. They did all these stents, all these studies with 2 millimeter stents, and so they have their own data that they can use as a historic control. So the FDA will only allow it in certain circumstances, I think, and it's when you can provide your own data. So we've seen a couple of other examples of this, and another example is maybe the Abiomed, the Impella ECP,
Yes.
okay, where it's not randomized, it's single arm, and the FDA will allow that because Abiomed has all the data on CP. So they can show the FDA, this is the data, these are the patients we're going to compare it to, and so they can match and do a match comparison with their own data.
That makes sense.
Okay? So maybe I wanted to ask a question to Pervais. Right now we're doing the DES ISR study, the magical ISR study, and you're the top enroller in the country, so thank you very much. To you and your team, we wouldn't be able to do this without you. Maybe some comments on how you've been so successful in enrolling in your center, particularly considering there is this agent balloon, right? So we often, I mean, those of us who are here, we're here because we like doing clinical studies, but one of the objections I often hear to people being involved in the clinical studies, oh no, I have a commercial device now.
Right. No, so it's a great question. So I think we are in a unique advantage right now to the fact that you brought up earlier. Financially, the agent balloons is not a feasible option for all patients. Realistically speaking, if we use the agent balloon on every single ISR or case that we would have, I think the hospital administrators would be, for lack of a better word, up my rear end. So that's not an option, really. So I think we're in a unique situation where the agent balloon just came out. So commercially available is not, it's available, but it's not feasible for everybody. So that's, I think, an advantage right now to enroll in a clinical trial. The second piece of it is that we are a very busy ISR site because we're also a brachytherapy site. And so we never really thought brachytherapy was a long-term solution to anything, but we had no options in the United States, to your point. So the coming of DCB has been a huge advantage to us. Obviously, as you all know, the clinical exclusion criteria is people who have had brachytherapy to an ISR before. So we can't include patients who have had brachytherapy, but we can include patients that have not had it. And a second advantage is that for those of you who have brachytherapy or are doing brachytherapy, the brachytherapy catheter has been on back order for the last year, and they've been having supply chain issues. So yet another advantage of right time, right place, a good study that we're able to enroll. So that's been the success. You know, we have a very busy population, and it's not just me. We have 10 interventional cardiologists that work in our health system that are part of the study, and we're all actively looking for patients, some of whom are in the audience. So it's a good team effort, and I think it's a good trial. We really think, as you do, as everyone on this panel does, think this is the future for where we need to be in terms of what we call PCI, not just DES, and I think this is going to be a great step in the right direction.
So maybe just one last quick question before we go on to the next case. Any thoughts so far? Have you noticed any differences in deliverability of the two balloons, or they seem pretty similar to you?
They seem very similar to me. I actually, the first time I used the Concept Medical balloon, I was shocked at how easy it was, and it was before I had used the Agent balloon, since we were not part of the original trial. But in using the Agent balloon, also very deliverable balloon. So honestly, as you said earlier, it's a balloon, and it's designed to be easily deliverable. The key, it's a conduit to get your drug in the right place at the right time. But I think your point earlier, lesion preparation is of absolute critical importance. If we want to see this area succeed, we knew this from the ISR stuff in the past, even with brachytherapy. Brachytherapy doesn't work if you just do brachytherapy. You have to actually do lesion preparation and do it the right way.
Andrew, you wanted to make a quick comment?
No, I was just going to say that it's a balloon part is important, but there are bulky balloons, right? I mean, there's like balloons that you know are not going to cross, and this is not that. So it's a good balloon.
So we have a case now. Prakash, please. You have a case of DB in ISR left main coronary artery disease bifurcation.
Respected chairpersons, I have no conflict of interest. What is actually the complex LM bifurcation with PCI? You have restenosis, late stent thrombosis, and then issues pertaining to the depth. So we have a choice that we can use Drug-Eluting balloon in bifurcation PCI, especially in ISR. I will go to the case directly. A 71-year-old man actually had an angioplasty in 2022. Then there is actually the patient with a creatinine of 9.3. Patient came with a restenosis like this. ISR, circ stent and ISR, LED stent, we did an IVUS. IVUS was showing significant restenosis at 1.73 is the distal part, in the proximal part is 2.28 millimeter square. We did a 3.5 into 12 millimeter balloon in circumflex. We could demonstrate a stent fracture in the previous stent in LAD even by the clear stent. So actually we did a balloon dilatation done into the IVUS. Proximal LAD, actually in the IVUS we could see some thrombus. That probably because of the stent was fractured there. We used a Wolverine 3.3 into 6 and 3.15 cutting balloon into the ostial LAD and ostial circ. And we used a Wolverine 3 into 6 into the mid LAD. Repeated IVUS again. We actually got an luminal gain from 1.72 to 4.14, 2.16 to 4, and actually 4.52 from 2.28. This indicates actually that lesion preparation is very, very critical. LMLAD pullback, we got an area of 8.91 in the LM, post LM, and we could see that we just used a drug-eluting balloon magic touch, 3 into 30 magic touch to mid to distal LAD, and to the proximal LAD, we used it circumflex 3.5 into 30, but we have to use a stent because of the fracture there in the LAD. That is the final result we got, and post dilatation into 3 into 6, we used only 8 ml of contrast because of the high creatinine. Patient was not on dialysis. This was a 65-year-old male, came with a 99% ISR in circ stent and 67% LAD ISR exactly after 13 months of intervention. This was angiogram. We could see ostial circ is restenosed. This patient actually had an IVUS catheter, could not be negotiated. We used a 2.5 into 12 millimeter balloon into the circ ostium. You can see that the ostium is actually, the balloon is difficult to go inside. After that, we did an IVUS again. To understand that, there is a significant, actually the area was underexpanded stent segment in the ISR part of the LAD or circ ostium. LAD was okay with more than 6 millimeter square throughout. So we decided to do a Wolverine cutting balloon at 14 atmosphere, 15 second, but circ actually not opened up properly. The next thing is actually we used an OPN balloon at 30 atmosphere, then went up to 40 atmosphere, and then 3 into 10 millimeter in the distal circumflex. Underexpanded area is actually well open. We can see from 3.69 we got up to 6.48. Once we got it, we used a 3.5 into 10 NC balloon both to LAD and circ. And then LAD evaluation post circ opening, we got 6.95. We got LAD, reasonably good area and everywhere. We used a 2 magic touch together. 3.5 into 30 magic touch to circumflex and 3.5 into 25 magic touch to LAD. We independently dilated each drug-eluting balloon for 1 minute 30 seconds. Then both the balloon together for 10 seconds. Then we got a 4 into 8 pot balloon to an LMCA and finished the case. This was the final result created after that. And this patient actually the last is 80-year-old male patient with ISR and LM bifurcation after 1 year again. We can see this case. This patient came to me with a circosteal disease. We used a 7 French EBU. No wire could cross. We have taken a Gaia second to cross to the circumflex. We dilated with a 2.5 into 10 cutting balloon in the circosteum, then a 3.512 balloon into the LAD. We pre-run OCT was done in this case. We could see the area is only 1.43. So that totally fibrotic lesion, not calcium is not seen there. Distal LM also having minimal disease there. ISR length was 16. We use a cutting balloon to circumflex, 3.5 into 10 Wolverine cutting balloon to LAD. Both balloons together, bifurcation, actually done a kissing. Then he used a magic touch, 4 into 20 into LAD, 3.5 into 3 into 15 magic touch, and finally 4.5 into 15 balloon into the LMCA, produced a result like this. So this was the last case, a 31-year-old female patient, Takayasu disease, post-cabbage patient, completely occluded LMCA. Patient came back with a severe angina. We actually did a retrograde approach to open the C2 LMCA. We used a Caravelle and a cyan black wire, finally negotiated, taken the wire, then we could not take the balloon out. Because of the balloon went up to LAD, that is Caravelle microcatheter gone up to the LM ostium, LAD ostium, then I could take a wire antigrade. Then finally, with the antigrade, we opened the vessel. Then retrograde system is removed, 3 into 12 millimeter balloon. We did an IVUS. We saw the plaque in the ostial LAD. So we decided to put a long stent of 3.5 into 26 from LM to LAD. And this was the result. Exactly after 3 months of LM intervention, the patient came back. This time, there was no big issue for crossing the lesion, but the pre-run OCT shows a significant new intimal hyperplasia. So here we used again a cutting balloon. We can see the tightest area was only 1.93. We used a flex tom. This was actually done 2.5 years back. Bifurcation pre-run. Then we used a magic touch from 4 into 20 LM to LAD and a 2.75 into 12 Maverick balloon to circumflex at 8 atmosphere. Then this was the final result. And patient is doing very well for the last 2.5 years. So this was the area we got 9.94 from 1.43, and this was the opening of the vessel. So DCB could be an excellent treatment option for side branch lesions and coronary bifurcation. DCB was utilized to treat the main vessel. Scarce data observed an increase in the ostial side branch area. ISR, definitely, it attenuates long-term data, especially with LM bifurcation. You can use both the magic touch together and create a good result. Thank you.
Yeah, I would like to comment on the fact that all of these cases have been done with intravascular imaging. So they were ISR management guided by intravascular imaging, which is, in my opinion, the way to go. And I wanted to ask you and Azeem also a comment on how important it is to use intravascular imaging for the magical ISR study. Which are the recommendations and all of that?
Yeah. So maybe I'll just use Ajay's words because he should say this. So, you know, when we look at in the agent study, I think, what is it, 68, 70% of patients had intracoronary?
74, yeah.
74% had intracoronary imaging, right? And you saw those curves I showed in my presentation, how well they separate. I honestly believe a lot of that is got to do with using intracoronary imaging in order to be able to get better lesion preparation. So what we've done in all the drug-coated balloon studies is we highly recommend it. You have to be careful in the United States about mandating it, because if you mandate it, then it goes into the IFU, and then you have to use it when you open a balloon, right? And we don't want to do that. But having said that, I think we're going to see increasing use. I mean, one of the things we need worldwide is better use of intracoronary imaging. I'm hoping now with the new European guidelines, where for the first time we actually have a class 1 indication to use intracoronary imaging for complex lesions, bifurcations, restenosis, left main. I hope that encourages a lot of you that there's a lot of data to support using it. It will make you a better interventionist. So we really think, we're hoping that in Magical we'll get 80 to 90% is what I'm hoping, intracoronary imaging.
It's also, I mean, important because, you know, it's very hard to expect a balloon that is an anti-proliferative, delivery vehicle to prevent restenosis when the reason the stent had restenosed is because it was underexpanded. And oftentimes you may think angiographically it looks fine, but if it's underexpanded, you need to expand it first before expecting the drug to do its thing. So from my sense, that was a reason that it's essential to figure this out. Even if you don't care about understanding if it's neoatherosclerosis or whatever, just know that the expansion is as good as you could possibly get, like the cases you showed, before then proceeding.
Actually, in India, now the imaging was used in 3% actually 4-5 years back. Now it is nearly 8 to 9%. But in LM intervention, we used nearly 40 to 50% of the cases in the country.
Yeah, it's growing in India like wildfire, so for sure.
Marco, you had a comment?
Yeah, I would just continue the discussion that you already started. You said that ESC gives class 1 indication to imaging, which is completely true. At the same time, ESC gives a preference to DS implantation in ISR based on studies in which the mechanism for ISR was not addressed by imaging, was just randomizing patient to death versus drug-coated balloon, which is a nonsense. I mean, as we were speaking, first you need to address the issue. Why do you have ISR? And then perhaps restenting is an option, but not necessarily the best one.
Yeah, I must admit, I'm very concerned about the downgrade of DCB in the current guidelines in Europe. And is that going to result in a lot more patients we're going to see with 2 and 3 layers of stent in the same artery, in the same segment? We're going to have to see how that pans out. But yeah, I'm concerned too.
Yeah, one of the challenges the guidelines committees have is they're in the unenviable position of being locked in by what the published studies show. And there's no published study that can be interpreted outside of the context in which it was done, i.e., was there imaging in the study, yes or no? They can't like factor that in as well. And also just the premise of, as a patient, would you want another layer inside a layer or would you not? That's like a very simple question that most people would say, no, why would I want another layer now? Because you could potentially put it in later if you needed to. So those very practical issues are very hard to assess when guidelines are written.
Ajay, actually, one more important point is in these ISR cases, otherwise is the absolute cases for surgery. Actually, there is one point we can even prevent a surgical treatment for those patients also.
Yeah.
So let's move on to the last presentation. Marco Valgimigli is going to tell us a little bit about complex cases with Sirolimus Coated Balloons and the TITAN RCT.
Yeah, I'm going to show you one case which is actually not so complex as the one we saw before, so I'm going to do my very best actually here. These are my disclosures. So perhaps this case is complex from a clinical standpoint because he's a relatively young gentleman with a very heavy cardiovascular history already. Basically, the patient has already 4 PCI, as shown here. Patient has type 2 diabetes, hypertension, dyslipidemia, overweight with some obstructive dyspnea, a mildly reduced ejection fraction. The patient has CAD, which required already 4 PCI, basically, 2 each in LAD and RCA. I would like to point out that the first DS implantation was actually in 2008 in RCA, 2012 in LAD. And then the patient stayed relatively well for years. But then the patient came back after some years. Again, re-stenting required, or at least was approached, was performed in LAD and RCA. Not at 1 year, not at 2 years time frame, but much later. The patient had a known CTO of posterolateral branch. And then the patient comes back for new symptoms. And again, a slightly further reduction of LV ejection fraction. So the patient got a recath. This is the RCA with a known CTO of posterolateral branch, which was not addressed before. This is LAD after 2 stenting procedure. Also, the diagonal branch was stented. Apparently, at least angiographically, we judged that to be a relatively good result. And there was a new lesion, the circumflex artery, which was not described nor present at angiography before. It's sort of an intermediate lesion, in fact, not dramatic one. So we FFR the lesion, and it was significant. So we decided actually to address that lesion as a potential culprit for the new symptoms, for the further drop in ejection fraction. Of course, that can be discussed. We are here to discuss the case. This is a relatively long lesion involving the first marginal branch. So the question is, how shall we address this lesion, taking also into account a very long history of stenting and stent failure of the patient? So we first started prepelling the lesion, dilating the lesion to see what you get. And we got an FFR, which was 0.87. By completely chance, Bernardo was just 1 point below the cutoff that you just described. I was not aware of the cutoff. But we decided that this delta of 0.10 almost change in FFR was more than enough. And so at that moment, we thought that a drug-eluting balloon could be a reasonable option, or at least that is a condition in which we thought there could be an equipoise between DCB and DS. And for that reason, we randomized the patient into an ongoing study, which is the TITAN DEB. Slightly different than the study design that we have seen before. These are only de novo lesion, irrespective of the stent of the vessel diameter. But there has to be long lesion, meaning at least 30 millimeter DS implantation as planning, the patient be treated without involvement in the study. The patient needs to be successfully dilated. We leave it up to the discretion of the physician. What that means, in my practice, that means that I am FFR guided, and I need to have an FFR of at least 0.80, otherwise I would not stop. And I need to have, of course, a T3 flow, and I need to have a decent, acceptable dissection that is not going to be threatening a vessel occlusion in 1 second. At that moment, the patient is eligible, and that patient got randomized into the study, in fact, to a drug-eluting balloon-based strategy or drug-coating balloon-based strategy. Note that the study actually is requiring mandating an angiography follow-up, either of 6 or 12 months, and the primary endpoint is the absolute delta in FFR post-PCI versus at follow-up. So the acute luminal gain is not part of the picture, which is why I have a problem in interpreting some of the studies that we discussed so far. This is again another design figure sketch of the study. I'm going to go there later. This patient got treated got randomized to a drug DCB. Magic Touch 3040 was used, a single inflation of 60 seconds. This is the angiographic results, which was deemed acceptable. I would say not that much of a difference to what we got before, but FFR was dramatically improved, which is not necessarily what you always see in these cases. Anyhow, the procedure was completed and the patient was discharged back at home. The patient was randomized into 1 year angio follow-up, so exactly 1 year afterwards, this October 2024, patient came back, was completely symptom-free. RCA was occluded, so it was a third failure of previous 2 stent implantation. There was a disease progression, including ISR of LAD, involving also the diagonal branch. Again, third, unfortunately, failure of prior stent implantation. And the good news, at least, was that circumflex, which was treated with Magic Touch, was absolutely pristine, angiographically speaking, not much of a difference. FFR, very good, of 0.90. So how shall we tackle now this patient with 2 new lesions in the 2 vessels which were previously treated? This is just to bring up the discussion we already started. This was the procedure last time we saw it in 2016 at the end of the procedure. You see that the result is relatively okay-ish at that moment. The patient got a second stent implanted in mid-LAD, and for the first time a stent implanted here in the diagonal branch. There was some sort of disease proximal involving this bifurcation, which was left untreated. Perhaps that was at that moment a good strategy, because 1 year before, in 2023, the lesion, angiographically speaking, was, I would say, very similar, whereas it got clearly deteriorated 1 year afterwards. So we did imaging to understand why this patient got ISR, and in fact, that's an interesting case because this shows in a single patient everything can go wrong inside a stenting procedure. First, the stent is underexpanded, there is some intima hyperplasia, and there is most likely some geographic miss, or at least now we can call it some geographic miss. The operator back then in 2016 didn't want to stent the bifurcation, so left this bifurcation untreated, and you see that now there is a clear progression of disease. So given the complexity of an ISR, having a very blunt recommendation from ESC guidelines that DES is recommended over drug-coating balloons for treatment of in-stent stenosis, it's a bit too blunt for me, too simple for me. I think not all stent failures are born equal, not one size fits all solution. And in fact, this case got an hybrid approach, got a new stent implantation in the proximal part where the stent was previously not placed. And of course, you don't want to get into a third layer of metal in the LAD. So there you go for a drug-coating balloon, and the final result was very good. Now, the concept between the TITAN depth, and with that I'm going to draw my talk quickly to a close, is that we assume, and actually we know already, that acutely, periprocedurally, if you get drug-coating balloon, the acute gain is lower than if you stent the vessel, but as long as we can have a good result and we can alleviate ischemia, that's basically we don't care. As long as long-term, we actually could perhaps lose less, or perhaps even better, could gain over what is supposed to happen in the drug-eluting stent business, where you know that you are a bit losing over time, not perhaps in the first 6 to 12 months, but for sure we have the data much longer term. And with that, I thank you very much for your attention.
So Marco, maybe I can ask the first question. I mean, this is one of the first times I see, I guess your study is similar, but where the primary endpoint is physiological, really, to see what the change in FFR is going to be, rather than an angiographic endpoint or clinical endpoint. So maybe a little bit for the audience, what made you change from the traditional endpoint to this?
This is a great question, and the reason that we got that design is because we thought that there would be some sort of positive remodeling, so gain after the procedure, meaning you use a drug-coated balloon. Of course, you are in a way linked not to gain as much as you could gain if you DS the vessel, but long term you could actually gain in functional assessment. You could gain in angiographic lumen, which is not what you would get in drug-eluting stents. Why did we choose FFR instead of an angiographic derived? Well, because I'm very skeptical on these derived indexes, to be honest. For example, IFR without adenosine at the end of the procedure is entirely biased and unreliable. So I'm still an old guy giving adenosine and measuring the delta in pressure, and I think that is still the gold standard. That's why we went there.
So I guess in some way it's to try and delineate, we always talk about uncaging vessels and not caging vessels. It allows better vasomotion. It allows more positive remodeling. So in some way, you're looking for some sort of surrogate of why a DCB could potentially be better than a stent. Is that correct?
It's completely correct. So I got convinced about using DCB a few years ago, where after many years of work, I put together all available studies, randomizing patients with the de novo CAD to bare metal stent or second generation DS. That meta-analysis got published in The Lancet, show a mortality benefit in favor of second generation DS. Now, if you look critically into that meta-analysis and you landmark all studies at 1 year, all gain is happening within the first 1 year. From day 361 onwards, a second generation DS is absolutely associated with the same outcome in terms of death, cardiovascular death, MI, stent thrombosis to bare metal stent. So all the progress that we have had so far is happening within the first year. We never tackled the very long-term follow-up of our patients, and my hope is that with DCB, that can be addressed, likely at the cost of some higher need for target vessel vasodilation in the first year. We spoke about reg cage-free. Some additional TVR, as long as the absolute delta is not dramatic, it's probably acceptable if you can have a long-term gain. So I think we need to move the perspective from 1 year follow-up to 10 years follow-up. That is the challenge.
It was very interesting, actually, in the case you showed with the circumflex and all the other vessels that restenosed, that circumflex, the second marginal, was on a bend, and the bend motion was entirely preserved in the follow-up versus the other vessels where it wasn't. So I think that there may be something there, and even in that trial, cage-free, they will have 10-year follow-up, so that's great, but up front, the downside penalty was minimal. So I think there's a lot of room for exploration of these, and congrats for doing the trial.
Yeah, and there is also a technical comment on your case. It's a single case, but I think it's very important. So we have, today probably we didn't have the time to overemphasize the importance of lesion preparation for DCB in any clinical lesion setting. You used a 2.5 balloon, then a trio balloon for lesion preparation. You had a 0.87, and then you use a DCB of the same size of the last balloon, which is a trio by 40. You kept it inflated probably, I don't know,
1 minute.
1 minute. And then you had a better physiological result immediately after DCB, despite the balloon was the same. So lesion preparation, going on, inflating, keeping it inflated for more time is associated with an increased outcome.
I agree. And we use FFR because it's very difficult to know when to stop and how to stop. And that's why at least we have an objective measure. We can discuss whether it's bad or wrong, but at least we have a measure.
No final comments for Vice? So thank you so much for joining us. Hopefully we've given you an overview of the whole drug-coated balloon landscape. As you can see, there are many clinical studies out there, so if you want to get involved, certainly in the Magic Touch ones, there's some people here in the front row you can speak to and see if you can join us in these studies. I think it's important for us to bring these devices to our patients in the United States. Thank you so much.